to the next part of the session. And as I said in the morning before we started, a very, very important focus of today's first part is the country perspective. So we've asked and we've invited a number of ministries of health to Copenhagen, representatives of the NCD divisions of the ministries. But we have also invited a number of persons with lived experience of type 1 diabetes. So in the next two panels, we will have representatives from ministries of health and representatives of persons with lived experience. The first panel is this, and I would like to invite the Ministry of Health of Tanzania, represented by Dr. Omari Ubuguyu, to the stage. Please, Omari. Yes, Ubuguyu, please. Dr. Ubuguyu is the Assistant Director of Non-Communicable Diseases with the Ministry of Health in Tanzania, and in fact also one of World Diabetes Foundation's long-term partners. I would also like to invite the Ministry of Health of Ethiopia, Dr. Hiwot Solomon. Please, Dr. Hiwot. Dr. Hiwot is the lead executive officer of disease control and prevention with the Federal Ministry of Health of Ethiopia. Please. And I would also like to invite a person with lived experience, Tino Tenda Tsikiti from Zimbabwe Diabetes Association. Please, Tino Tenda. And finally, last but not least, I would like to invite a person with lived experience, Nupur Lavani from Blue Circle Diabetes Foundation India, please. And we will start with a presentation by Dr. Ubuguyu, who will give us a short overview of the work undertaken in Tanzania. Please take the stage here, Dr. Ubuguyu. Thank you.
Okay, good morning. Good morning. Okay, my name is Omari Ubuguyu. I'm an assistant director for NCD Mental Health and Injuries from Ministry of Health in Tanzania. I'm a psychiatrist by profession, not an endocrinologist. And luckily enough, our section has been led by psychiatrists since its inception in 2009. So we are forced to channel everything within the group rather than having a single trajectory. So integration started from the departmental level. I'll just take you through the milestone that Tanzania has passed through, current practices and challenges that we have observed, and proposed model of type 1 diabetes care. Let me start with the country profile, because my case, I'll be making my case later on after understanding the profile of the country. Tanzania, as a United Republic, is a union of Tanganyika and Zanzibar. This is mainland Tanzania, and we have Zanzibar. The country operates with two governments. Zanzibar is semi-autonomous government, while the mainland Tanzania is within the federal government. And the Ministry of Health is different. We have a Ministry of Health in Tanzania and a Ministry of Health in Zanzibar. So I'll partly presenting on behalf of the mainland Tanzania in this, but we are working together in most of the issues, especially on diabetes and other non-communicable diseases. It is a country of 61 million people and almost 100,000 1 million square kilometer as size of the area. and we have life expectancy of around 66 years of age, and almost two-thirds of the population are below age of 25 years. So it is quite a younger population. Our healthcare system is like you, and we started at the bottom with a dispensary and end up with a national hospital. It is very important to note on this that almost 80% of people seek care at the primary health care levels, and only 20% who are seeking care at the tertiary level. So whatever that we are doing, and if it is anchored at a regional referral hospital or at a national hospital or specialized hospital, you will only cater for 20% of the population. But the rest, majority, 80%, within seek care at the primary health care level. We started type 1 diabetes clinic in 2005. Back then, we started with diabetes clinics with support from WDF at Muhimbili and Itemeke Hospital, whereby we had both type 1 and type 2 patients get services within the same environment. And then with support from Life for a Child, our colleagues, Dr. Edna, Professor Kaushik, and the team, they decided to separate the adults from the juvenile. And then we established type 1 clinics with only 30 clients, only one facility in Dar es Salaam, which is biggest city in the country with all of access to care. So out of 45 million Tanzanians, only 30%, only 30 patients had an access to type 1 services, and it is only in one region at the tertiary facilities. But thanks to the support from our colleagues, WDF, Life for a Child, CDIC, and other colleagues who are working with us, we manage now to increase number of sites from 1 to 83, covering all regions in Tanzania. At least all regional referral hospitals had type 1 diabetes clinics, and with support of other colleagues and lesson learned from Pain Plus and other innovation, and now we are taking type 1 diabetes care into the primary health care level. So out of 83 facilities, there's a tertiary facilities, secondary, and primary health care level, and that we are testing different models within our clinics. And mind you, initially this was a TDA and WDF-led initiative, but at the moment it is a national NCD program owned by the government rather than by these two organizations. And from 2019, we decided to take down the NCD care to the primary health care level. This is a health center, which is almost a third level of care within our healthcare system. And back then, we trained almost 3,000 healthcare workers. The highest on the link was medical doctors with MDs, but the rest were assistant medical officers, nurses officers, because we have learned from many programs that these cadre also can give a tremendous support when it comes to care. And thanks to WDF and the team, during the initial training, we also had a leverage of having some of the key equipments. When we started the service, we had a chance to see the trend of type 1 diabetes. It was increasing. Probably with improved access, most people also seek care, and the number of the patients goes on. Who knows, if we be able to saturate all our facilities with type 1 diabetes care, we could probably have much bigger number of the patient. So increase the access, also increase number of the people who sought care. And again, we are privileged also to learn the trend, because we had so many clients on the line, and then it was easier to predict the trend. When we have more clients in which month and in which season could probably have similar pattern with our colleagues in the West. So it is easy to learn. And again, we realize that it is not only medication or diagnosis that our patient needs, also they need education. They need to learn to live with a chronic condition. They have different needs, but we also needed to empower them because they have to speak for themselves. And we all know that in this community, all people say that nothing for us without us. So we used to empower them. And this empowerment is not only to the people living with the condition, but also to other children in school. So we have school programs making other people who don't have the problem understand what their colleagues are passing through, and it is easy for them to support each other. So the school programs is not only for those who are living with the condition. Again, when we did some interview with the patient and their caretaker, we realized that there's a lot of stress, a lot of mental issues, a lot of challenges with them. So we established mental health and psychosocial support intervention within the groups. We give them some relaxation therapies, and sometimes we do sports, things like that, to make them move and build their self-esteem, because some of them miss medication because they feel ashamed to inject themselves during working hours or when they are in schools. So building the self-esteem and self-efficacy, I think, was one of the key issues, and it is embedded within the programs. We also learned that our follow-up mechanism within type 1 diabetes is not as much as strong as with the TB and HIV care, because we have a lot of lost to follow-up. Almost a third of our patients are lost to follow-up and 6% dies. But the programs only cater for those who are under 25. For those girls beyond 25 years of age, they graduate from our programs, and we don't have a very good tracking mechanism at the moment. So some, we meet them along the way. So there's a number of challenges that we've observed, but for us, these are not challenges rather than the lesson learned during the 20 years of implementation, and we would like to share with you here today. At a macro level, when you look at the bigger picture, we have learned that we need to create a policy enabling environment which could push the agenda, and thanks to Professor Kaushik and the team, we have been doing it, and I'm sure there's something to learn from us. Again, we were looking at our system and realized that it is designed for the acute care. All of us are providing care and forgetting that this patient will come again next day. And this is different from malaria, because most of our people are used to malaria and diarrhea. Even the patient themselves, when you are giving them medication, they ask you, this medication going to cure me? If not, people are looking for alternative care, because they are looking for the cure rather than control of the disease. So we have learned that some of those challenges, again, at a meso level, these people living with type 1 diabetes are not immune to other non-communicable disease, but social determinant issues, and they are much more exposed to other risks of NCD, and probably difficult to control their conditions, and there's a lot of issues related to care. This is an additional slide that I put, and I want all of you to reflect. One of the biggest issues in our community now is the use of SSB, and most of youth likes soda, Coca-Cola, and the likes. So type 1 diabetes kids are also not exceptional. They are also prone and exposed to some of these SSB. Again, in our population, this is a general population of adolescents, 10% are reported to have suicidal tendencies. These are normal children, these are normal youth who have no chronic conditions. So you can imagine what is happening with those who are living with a chronic condition. Again, on the other NCD risk, thanks to Sanjana, you recommended, especially on the issue related to best buys. When you're looking to physical activities, most of our children, our youth, their lifestyle, their sedentary behavior goes as high as 20%, and only a quarter who are physically active. But when you go to the adults in Africa, 80 to 70% are active. So this is a different population when you look all across. So these are the very important issues that we put into consideration when we are preparing our program. So these are some few issues that I wanted to share with you as part of the lesson learned in Tanzania. Could probably get some more input from your side. One, creating enabling environment. This is inauguration of a national NCD program. We were doing just the project, and then we converted into the program, and it was a Prime Minister of Tanzania, who was the head of the all ministers in the country, who launched it. And luckily, we had our brother Bent during the launching in 2019 as part of the initiative. But we use multiple avenues, especially on the integration of care. One, in creating enabling environment. One, we are using a government, but we penetrated even in the parliament. So, picture on the light is former Minister of Health. She was handing over NCD prevention booklet to the Deputy Speaker of the Parliamentary of the United Republic of Tanzania, and to the left, it was a meeting with Tanzania Diabetes Association, Minister of Health, and we had a conversation with the head of the parliamentary committees, because we know NCD is not an health agenda. So these are heads of committee on transport, on finance, education, and other social services. So all the heads, we take them through, they understand, and they are part of this initiative. Again, we are focusing on integration of type 1 diabetes, but mind you, whenever that I'm putting type 1 diabetes in our desk, we are talking of NCDs in general. So the agenda also is integrating it at a primary health care level, but there's a good lesson learned from other interventions. For example, HIV prevalence in Tanzania in 80s went as high as 20% in some of the regions. And maternal mortality 40 years ago was as high as 540 out of 100,000 live births. But with the workforce, just from nurses and clinical officers, the maternal mortality dropped from 540 to about 100. And HIV prevalence goes as from 20 to almost 4%. And 80% of the workforce were nurses and clinical officers. So we know for sure, taking this intervention at the primary care health level, it will be very important, because we increase access, and those with complications are the only one who will go higher to the secondary and tertiary level of care. Again, integration is not only at the healthcare level, but also within our patient community. We have consortium of the people with lived experience that contain people with mental health condition, those living with sickle cell, those living with cancer, those living with diabetes, both type 1 and type 2. So it is integrated within people with lived experiences. In Tanzania, in most cases, we are not talking of type 1. We're not talking most of sickle cell. We are talking of non-communicable disease, because we know most of the risk factors, most of the interventions, and people who are intervening are from the same community. Again, to improve access and supply, we integrated all commodities and insulin, even those which are coming from philanthropies, we all channeled through medical store department, and the reason is, one, we want them to be familiar with this, but again, we create appetite within our facilities when they know it is easy to access and they know that we are accessing through our medical store department. It is easier to budget and plan within their annual plan. Again, thanks to Diabetes Compass, with Health Management Information System, we started at the pilot with the Diabetes Compass. We were just wanted to pilot within 16 facilities, but luckily, when we started, the government also put resources into it. At the moment, we have more than 2,000 facilities connected with the Health Management Information System, which is electronic, but with the seed fund from WDF, we are able to scale up Health Management Information System. Again, we have National NCD Research Agenda, which moves research agenda within the community, and thanks to Pen Players again, they give us some of the highlight on the integration, because we have almost 3 clinics at the moment with Pen Plus. Apart from those that I've presented, but we have also seen some of the challenges within the juvenile group, especially those living with type 1. So we encourage our colleagues also to adopt WHO best buys, because they are also prone to other non-communicable disease. Tanzania has passed the Universal Health Insurance Law, and this year we will start, and we have identified some key community that we will start with and scale up. Hopefully, by 2028, the entire population will be covered with National Universal Insurance. Again, to reduce fragmentation, we know for sure when you have donors and philanthropies and professionals, when they come into our settings, they come with their own agenda. And in most cases with professional, they are just focusing in on a single condition. And probably in most cases, we've learned from our colleagues from the HIV and TB groups, we do fragmentation, we pull resources into one care and leave the rest with the meager resources. So integration at the resource level and implementation level, which is very important. Again, having a solidarity fund, which collects both government and donors' funds into the single basket is one of the key areas. And again, standardization of the price, because the commodities are sold at different prices and it is very difficult to control. So as a country, now we are standardizing prices. So in a nutshell, these are some of the issues that I wanted to share with the colleagues. And thanks to all of these key partners who are continuing supporting Tanzania. Thank you.
Thank you very much, Dr. Ubuguya, and we had hoped to have comprehensive, or you can say a comprehensive overview of country implementation framework, and certainly you gave us a very comprehensive overview of an implementation framework. We will, of course, allow questions to Dr. Ubuguya a bit later, but we will move on, in fact, with the second country presentation now. And I would like to invite Dr. Heward Solomon from the Federal Ministry of Health of the Republic of Ethiopia. And Dr. Heward comes from a background in the ministry, different programs, TB, other programs, and before becoming the lead executive officer also in the NCD department. So I guess if we discuss and aspire for integrated care and reforms where different disease groups are converging, Dr. Heward comes with that experience from the different sectors. It also reminds me that the bios of all speakers are also here on the QR code if you want to know more about the speakers we have with us these days. Well, over to you, Dr. Heward. Welcome, please. Thank you very much. Let's give an applause to Dr. Heward. The green one, yes.
Okay. Thanks so much. It's my pleasure to share with you the Ethiopian diabetic program experience. Maybe just to give you, before my presentation, regarding Ethiopia. Hopefully you all know about where Ethiopia is located in the eastern part of Africa, mainly the Horn of Africa. It's quite a big country in terms of area as well as population number. We do have also many diversity in terms of topography and language and so many factors. So having said this, based on the given outline for this particular session, I have an introduction slide regarding the DM and other NCDs, also type 1 diabetic capacity building efforts in general, and also partnership, mainly focused with international partners working on type 1 diabetic, and also the challenges and the way forward. Just to give you the information regarding the burden of diabetic mellitus in Ethiopia, according to our STEP survey, in fact this one is conducted a long time ago, in 2015, it was estimated about 3.2%, and there is also little bit variation among male and female, and for male 3.5% and female is 3%. Also, from the IDF study reports, like age group like between 20 and 79, this is also an adult group information. It was estimated about 5%. There is almost similarity between those reports. Also, about 1.92 million individuals are expected to live with DM, and among that, 192,000 are expected to be type 1 diabetic patients. So from age 44 up to 94, about 72%. This is from the NCDI Lancet Commission report. Also, it's some years back, and it was expected up to 84% of individuals living mainly in the rural part of Ethiopia doesn't have any access problem and still don't have information about their status. Also, from the STEP survey, about only 24% of patients able to have a blood sugar level of control. So this is really a very small number. We are striving to improve this number for better coverage. In general, we do have a national strategic plan for non-communicable disease, and the strategy is primarily focused on CVD, DM, cardiovascular disease, CKD, and risk factor mainly. This is across for these major NCDs, including tobacco control, and also focusing on harmful alcohol use. We do have also substance and chat mainly in Ethiopia, and also giving due attention for physical exercise and air pollution. Maybe recently the government also give a good priority in terms of having healthy lifestyle, mainly using the physical exercise, walking streets, particularly in the major towns and so on. So our strategy have a vision. The vision is to see healthy, productive, and prosperous Ethiopian, free from preventable and avoidable non-communicable disease and mental health condition, in fact. So the mission is encompassed with the equity and quality of the service to deliver all packages at all level of healthcare delivery. In general, we have also a goal to reduce the burden of non-communicable disease and also promoting healthy lifestyle in general. And we have, in fact, very ambitious target. The target is 0% increase in prevalence of rising blood sugar diabetic, yeah, as I indicated, the prevalence was like 3.2% in 2050. And in fact, we are currently conducting the second step survey, and we are expecting a much better report from the current survey. Also, at least to have 50% eligible people receiving drug therapy, quality drug, and this was a baseline, 28%, and we are aspiring to go for 50% of the coverage. And this is also similar with WHO recommendation to have 80% of availability of affordable basic technology and essential medicine. And this is also very small number from the recent, not in fact very recent. We do conduct SPA survey, service level availability of major intervention in 2018, and at that time it was 28%. So the target is 80% now. Also, to increase the percent of people controlled for diabetic from 24% to 60% by end of this year. We have also priority areas. Mainly, we are focusing to bring boldly the issue of NCDs at the health sector strategic plan, and this is already achieved target, and it's one of the priority area among the health sector strategic plan with the recent one, and also NCD governance. In fact, in Ethiopia, we are very advocate for the integration of health service. We don't have any kind of silo program in the country. So integrate and leverage all program, including NCDs and the DM conditions. Also, multi-sectoral engagement. We do have a kind of draft policy document, and we are advocating through our ministry, and hopefully by Prime Minister level, this document will endorse, and we get much better concern by engaging all stakeholders at line ministries. Regarding the type 1 DM, we do also conduct a different capacity building activity through the support of different partners with our association, EDA, Ethiopian Diabetic Association, and other stakeholders, so that we have different projects in country. More than 20,000 children are beneficiary of this different platform and projects. In fact, Ministry of Health, together with a partner, also revised its protocol and also provide a kind of updated training material to have a kind of uniform understanding among the health provider at different level, so that so far we have really have many progress in different corner of the intervention and delivery at different parts of the country. Regarding the partners, we do have, in fact, quite list of partners. I will share with you, like Novo Nordisk, WDF, also direct relief support, also Panorama patient. This is for the economic empowerment. The same with Rotary International. We recently have CHAI in a few areas with few facilities, in fact. Also NCDI Poverty Network by providing kind of study and prediction. This is kind of evidence generation part, and also supporting the policy brief. We do have also Red Cross International with different scope and engagement level. In general, Ministry of Health highly working with the Ethiopian Diabetic Association. We do have a long-standing partnership. This is very instrumental for improved health delivery for diabetic patient, mainly for type 1 diabetic. As you can see from the slide, these partners and other stakeholders are aligned to support the diabetic care in general in Ethiopia. And I like to also extend the Ministry of Health heartily appreciation for all these stakeholders. Also, we do have international partnership. It's kind of follow-up extension of that slide. Above international support, we are providing many trainings and also capacity building at different level. at different hospitals. The other thing is we recently bringing the service down to the PHCU level, and most of our training materials and guidelines are also reflecting this kind of guidance in general at federal level to advocate and engage the NECD service administrated at lower level, and that will really serving a better opportunity for the beneficiary and in general for the community. So we have a kind of challenge during all this implementation. One of the challenges is related with the supply chain service. Also, we have a limited capacity. In fact, the prevalence looks like 3.5 or about 5% prevalence, but the service we provide is not comparable with the need, so there is a huge gap between the need and the capacity to deliver the service. Also, it's important to have a quality service in terms of logistics management. Because of the nature of this supply, we really need to have a cold chain and all related logistics management. And we have also issue with the data, starting from recording, translation, and also in general, quality data is one of the issues needs to be improved for the future. So as a way forward, mainly we are based on the current gaps and challenge of the program. We want to improve and also have integrated service at PHCU level. So we are calling all stakeholders and partners and potential partners in the future to work with us to focus on PHCU level service delivery. And we also appreciating the WHO PEN Plus approach, and we are almost finalizing our new project plan to expand the service at least at 150 health facilities. So the other thing is to improve supply delivery. The good opportunity we have, the ministry agencies that working on supply management. This is one of the key stakeholders in this regard to improve and support all the general service delivery and supply management aspects. Also to continue and expand the enrollment and number of beneficiaries in general. Also fully to implement CDTI 10 digital patient registry system that really helps to improve our data management and data related problems by visualizing our data and by having a better recording and reporting system in general. And it's already under discussion and it's on track, I can say, in this regard. Also, capacity of health professional and capacity of health facility should be further strengthened. So for this, job aids training should be intensified and so on. These are some of the experience from Ethiopian context. Thank you so much. አመሰግናለሁ.
Thank you very much, Dr. Hewood. It was a very, I would say, impressive summary of many activities in the NCD area, diabetes area, and type 1 diabetes area. You also described some of the implementation frameworks, the policy, but also the international partnerships that are, of course, very important for our meeting today and tomorrow. We have now had two very interesting and important country presentations. And as I said in the introduction, we would like to get some reflections from persons with lived experience of type 1 diabetes. And we've invited you, Tino Tenda from Zimbabwe, and you, Nupur, from India. And I had asked you in advance that when you came here, you would be in the panel and you would hear two comprehensive country presentations from respective Ministry of Health leaders. And then I asked you to consider, when you heard those presentations, from a broader perspective and with your background as advocates in your country context, but also global advocates, to reflect on what you have seen as explained and elaborated by Dr. Uboguya and Dr. Hiwot. And I'll start with you, Tino Tenda. Please share with us your reflections in general terms, the progress we've seen in these two countries in light of your own experience as a person, lived experience, and of course your role as an advocate in Zimbabwe and worldwide. Thank you.
Great. Okay. Thank you so much for the great question. Okay, so I thought maybe. Okay, so I think me as a person living with diabetes, so thank you so much for having us as people living with diabetes to also give our own reflections on the perspective of people living with diabetes. So I believe, yes, with everything, because I don't just learn these from the doctors, and also because I have friends from these countries or this context. So usually we discuss, because most of the times I'm involved in having to represent them as a global perspective, like maybe representing Africa as a whole. Sometimes I do engage with them. I have great friends from Tanzania and also Ethiopia. So sometimes, like when you learn of these things and then you're also hearing them maybe from the ministerial perspective or the points, where they'll mention everything that is happening in these countries. So yes, we believe maybe the realities of people living with diabetes. Yes, we are not where we are supposed to be yet, but I think I'm pleased with the progress that we are making or that has been mentioned. Yes, sometimes it's also great to know that so many things are happening in your country or things that are going to help people from your country to improve care for people living with diabetes. But sometimes it's also great to be also involved in this context where you're also part of it, contributing and being like maybe part of the panel, or sometimes being on these, maybe sharing from your perspective sometimes, because like if I'm to talk about what I do in Zimbabwe, where I also sit on the boards with the Ministry of Health, working closely with the Ministries of Health, working also with the hospital, some of the hospitals, as a volunteer, because I just want to see care improving, also sharing from my own lived experience as somebody who has explored, like also learned from other perspectives, especially globally, from friends who also share how they do their things, like peer support. Yes, it was mentioned by the assistant director, Omari, that we say that there's nothing about us without us. Yes, we believe that we need to be part, we should not just be included on the peripherals or on the checks, just to say we're involving people living with lived experiences just for the checks, but they should also be central in the decision making. You need to learn from their perspective, give them equal rights. I mean, because we also, as people living with lived experiences, we should be seen as experts. We believe we are. We may have our backgrounds. Sometimes, yes, when you come to conferences, yes, we are only talking about us living with diabetes, but we have backgrounds that we don't usually talk about. I have background in finance, and now I want to venture into public health because I'm interested in this. I don't just want to just speak from the lived experience. I also want to speak from a global perspective to say, like, what is happening in other countries? If other countries could achieve this, so how best can we also, in our own context, how can we achieve this so that care could improve? So, yeah, I think that's what I could say generally.
Thank you very much, Tino Tenda. And these were exactly the reflections I hope you would try to convey to us all. And I'll ask you the same, Nupur. With all the work you've been doing in India with the Blue Circle Foundation, it's impressive. You heard two country implementation frameworks from East Africa, and as I asked you in before we started, your reflections in a general term. You hear two ministers of health representing large-scale implementation, and again, as Tino Tenda said, what is meaningful engagement? Not only as an activist or a voice, but also as a person with lived experience representing many thousands in India, for example. Please.
Thank you, Ben. Thank you to the WDF and colleagues for this incredible meeting. It's been wonderful hearing everything over the past 2 days and reflecting on comments made by colleagues on this panel as well. I've been living with type 1 diabetes since the past 29 years, and I'm from India, which is a country with a massive population and a massive burden of diabetes as well. We've got about 136 million pre-diabetics, 101 million diabetics, and the highest population of young people with diabetes between the ages of 0 and 20. So as you can imagine, the prevalence combined with the challenges of being a low and middle income country are immense. Every single human being on the planet deserves to access healthcare that is accessible, affordable, and without any financial hardship. And we all know where we stand. More than half of the world's population cannot access the healthcare that they need to get. And it's the same with people living with type 1 diabetes because it's a chronic long-term condition and it's not, that you just medicate and that's the end of the story. We are living with the condition until the end of our lives. I want to talk a little bit about the out-of-pocket expenditure faced by people, especially in low and middle-income countries. And I also want to congratulate, from the Ministry of Tanzania, our colleague spoke about, implementing the law on universal health coverage. And I think such a forum is an amazing place for countries that are in, for low and middle-income countries to learn from each other. How can we advocate to our governments to do something similar? What can we implement given the limitations in budgets, in service coverage, in finding a way to have sustainable financing for type 1 diabetes? A lot of people are pushed to the brink of poverty because they simply cannot afford insulin, test strips, and other devices and medicines that are needed to keep them healthy and alive. So I think, it sounds like a little bit of doom and gloom, but there are still things that are working and that are happening well. And I'd like to quickly reflect on what's working in India. So what's definitely working, and we know this to be true, is community and peer support groups. We've been talking about it, since yesterday, and I think they're a brilliant bridge between an overburdened healthcare system and patients who are seeking help and who cannot afford help in many cases. So certainly having a community and someone, a community to fall back on, to talk to, someone who gets it, understands, doesn't judge you for who you are and what you're going through. I think that is really crucial, and that's a positive. That's something that is working and that has come out of this adverse situation of people struggling to manage day-to-day living with type 1 diabetes. Other things that are working are digital solutions. A lot of us are connected and have been connected since years. Some of us may have met a couple of times over the years, but have a longer connection over a decade or more, thanks to the power of digital and social media platforms where we connect and we talk to each other and we learn from each other. And there is no formal, mind you, there is no formal structure to this learning. And that really is the beauty of the diabetes online community, for example, of sessions such as these, which are, while we are here in person, there are a lot of other colleagues that are also watching us online, and we know we have a ton of our friends, who are watching us and cheering us on and sharing their thoughts as well. Another thing that is working is, I'd like to also talk a little bit about the availability of generic and biosimilar medication, especially for low and middle income countries. I think it's something that isn't spoken about as much. In India, we have something called the Jan Aushadhi Kendras, which are government-run pharmacies that sell medication at affordable prices, including generic and biosimilar medication. And that is definitely something, because quite realistically, we cannot expect we wake up after September, after the HLM, and suddenly we've got UHC, or it's certainly not happening. And so, how do we get there? I also want to emphasize on the urgency of, it's not just that we have a target and 2030 is when something has to change. Whether it's 5 years or longer, I think we need to have a clear, practical roadmap on how we are getting there. The burden of NCDs, especially in low and middle income countries, is massive. And we study it, we know it, we live it. So there's a lot that is working, and there are the good things that are happening that need, support and collaboration. But there are some things that should change as well. And this is the last part of what I wanted to say. And, our colleague here talked about fragmented healthcare, and that is something that, I was thinking about last night as well. We cannot work in silos. We have to, look at type 1 diabetes as part of a larger NCD network, and that then as a part of a larger UHC program. Are NCDs part of UHC programs in our countries? Do we have national policies on NCDs? Are they operationalized, to be successful? Are we able to, are patients able to get something out of the policies that have been created for them? Have they been part of that sort of policy making from the start? I think these are questions that need to be reflected on. And I also really want to focus on the financial protection aspect of it, and the need for healthy markets. So recently we've been struggling in India with a problem with CGMs and lack of access, because there are few players, and there are challenges that we are facing, with the access to affordable CGMs. In fact, by this month end, most of our community will not be able to access CGMs anymore, because a certain company is discontinuing an affordable option that they used to have in the market. So in this case, what is the plan? We cannot wait till 2030. What will we do in the next 15 days when our CGMs run out? I'm on my last CGM that was part of the lot, that from the affordable CGM that was available in the market. So I think that the sense of urgency needs to come in, because lives are at stake. People are really finding it challenging. There's a small percentage of people that can buy CGMs in low and middle income countries, and even if we filter down further, it's just making access very, very difficult. So there's something that needs to be done on that front as well. And finally, and I can't say this enough, I think there's a need to really institutionalize, peer support, and the need for people reaching out to each other and connecting with each other, and recognizing formally that there is some sort of value in. I can say this. In my 29 years of living with diabetes, I've learned the most from people that have diabetes. It's often challenging to see a doctor. You're part of the health system. You see a doctor for 5 minutes, but the rest of, the 95% of your life, you're living on your own. You're making decisions that impact your blood sugar at every point. So, but in conclusion, and I really, I'm going to liberally use the words that Jean-Claude used a while ago about it really. I don't know if I'm saying this correctly, but it really activates my electrons, like he said, and to see what future collaboration happens from this wonderful meeting here in this room. And I'm sure, in September and beyond in 2030, we'll all be, looking back and, hopefully applauding ourselves on the work that's happened. Thank you.
Thank you very much, Nupur. I don't think in the organizing committee when we wrote the concept note that we had used the phrase activate electrocytes or what it was, but I think we get the point anyway. It's good that we have gathered a group of stakeholders and communities where we get such reactions from you, Nupur. We have a few minutes still. And while I'll continue asking questions to the panelists, please raise your hand so that I will not have time for questions, because there are many hands. Okay, we have the microphones ready? Yes. We'll start with you, Emma Klipman. And I'll please ask you to be very brief in your questions and introduce yourself.
Sure. This is Emma Clayton.
So that we can allow many questions.
Yeah. Emma Clayton from Life for a Child. This question is to either you, Tino, or Nupur. So anyone involved in the global diabetes space will know Tino and Nupur well for their entrepreneurial spirit. They have not waited for permission to advocate boldly. But the question is to either one of you, if there was one thing that global actors and organizations would approach differently about how to meaningfully engage and operationalize the lived experience, what would you change about that?
Yes, please, Tino. And let's try with brief responses so that we can have many questions.
Great question. Okay, what I would say is, just like any other expert who gets to be in a room for people living with diabetes or any NCD, if they are to be engaged meaningfully, we say they need to be seen as experts as they are, right? And also, if there are any allowances that people are getting, they should be getting that as well, not to be just called like as volunteers, because some people might not really feel like, okay, should I be doing this? Am I valued enough? That kind of a thing. So people needs to be valued for their time that they're giving, because it's everything. Advocacy is difficult. So if we are to be engaged by maybe the ministry or whoever, people needs to be compensated for their time and their value. That's what I think.
A brief comment, Nupur, from you, very briefly, please.
I think that the capacity building, in addition to what Tino said, the capacity building of advocates needs to happen. But because, like you were mentioning earlier, we all come from different backgrounds. We may not necessarily have a background in public health or global health. So bringing us up to speed on what needs to be done, I think, is also helpful. Thank you.
Next question, please. There were many hands. Yes, behind Emma. Please introduce yourself.
Okay, good morning. Thank you so much. My name is Phoebe from Kenya, pediatric endocrinologist. My question is to Dr. Omari. I do appreciate the work you're doing in Tanzania, but I'm just wondering, how do you balance the cost effectiveness with the health outcomes out of these patients who are living with type 1 diabetes, in terms of glycemic control, the psychosocial adjustments, the growth development, and name all that? Because we know our health facilities in the lower middle income countries are overstretched in terms of the human resource, in terms of the diagnostics. And the studies that have been done around East Africa, we've seen that the glycemic control has basically remained above 10%. And we are looking at moving away from just focusing on acute care, but rather chronic care to prevent microvascular complications and improve the life expectancy. Yes. So how
yes,
are
please.
we...
Let's get the response from Umari, please. Thank you for the question.
Okay, thank you. At the moment, what we think with the integration, we reduce burden to few endocrinologists and pediatricians who are dealing with these patients, because we know generally most of the conditions can be managed at the lower level. So we involve more human resource working with the patient rather than stretching the few at the tertiary level. When the team from TDA and colleagues did analysis of glycemic control among diabetic patients, there was a little variation from the PHC and tertiary facility, showing that most of the care are self-care, and we need them to be empowered. So when you empower service provider at the lower level, I think we improve the cost effectiveness because we use a little to train them. We use a little to provide commodities, and also patients spend a little on consultation and accessing care. So we think it is cost effective at a national level, at the healthcare system, and including to our patient. In terms of control, we are not yet there, but there are some significant improvement when looking at how our patients were failing 10 years ago and at the moment.
Yes, we can have one more question. Yes, behind. No, sorry, let's have here in the front. Here, yeah, Eric.
Hi, I'm Erica from the Swiss government. The question goes to both countries and as a representative of Ministry of Health. I mean, how do you ensure that your evidence and the efforts you are doing at the country level feed and are brought to the level, are feeding norm setting at the WHO level? I mean, your role as member states, when you negotiate in UN fora, to what extent do you bring this evidence? And how do you contribute to shaping the global norms and resolutions and etc. at the global level?
And this is a year where we have a UN high-level meeting
Absolutely.
on NCDs in New York.
That's why I'm asking this.
Let's get this.
Because otherwise it's not evidence-based, as it's only, there is a risk
we
of...
have a window now of informing the policy process. Please, you will start with you, Hebert. Dr. Hebert, please.
Thank you so much. This is a very, very important point you raised. Of course, as policy level, one of the issues is to understand the context of the local population and health service delivery. In other part, it's very important also to lobby the global community and to bring the attention at higher level. As member state, we are that privileged to share the experience and also to make noise at higher level. So on the previous WHO meeting, always Ethiopia reflecting the NCD mental health and also the DM issue as part of one of the priority areas as country what statement we deliver to the high-level meeting. So one of the problem is, in fact, the problem is rising. At the same time, it's really not going with that, the level of support we get from the globe, because most of non-communicable disease is not supported by partners or donors. So it's important to get to provide access for the community with reasonable quality health service, particularly with the medicine part and other care level instrument and supplies, so that we need to get affordable price and also affordable and at the same time quality supplies. For that we reflecting on the country statement, the member state to consider other stakeholders to give due attention for a better service in the future. So it's always in our table, and that's one of our area. Thank you.
A quick also remark from you, Obugui, very briefly to the question from Switzerland.
Okay, thank you. What I presented here is just a programmatic report. There is no analysis on it. But as a country, we have national research, NCD research agenda. And with support of TDA, Ministry of Health, and WDF, we are sponsoring PhD candidate, masters, and undergraduate to use secondary data, doing analysis and publishing a report from that. Again, we have NCDI and Poverty Commission, and now they are doing PEN Plus research in the country, looking on those reports. And we have a number of initiatives within ourselves that given sponsorship to do research in various topics within our NCD intervention. And again, we have opportunity of presenting in meetings in EXA. Next week, my minister will be presenting at EXA, Eastern African Region conferences. I was presenting last week again within the NCD coordinator within the East African region, and we are here today, so we keep on pushing and welcome some of the researchers, young researchers, come to Tanzania. We have a lot of the secondary data. We can work together and do some analysis. Before September, probably can have a number of publications together.
Thank you very much, Mbugwe. I really appreciate that invitation. We'll have a last question before the break. And please here at the front. Susanna here, please. Please introduce yourself.
Thank
and
you so
make
much.
the question very brief, please.
Very brief. My name is Dr. Robert Salamte from Ghana. I'm very intrigued and impressed with all the progress from Ethiopia and Tanzania. Just have one question on sustainability, especially for Ethiopia. You mentioned that the partnership with international donors is filling a big gap. What are your plans for sustainability? Because I don't think these partnerships will last forever, but it's really impressive, and hopefully I'll talk to you and take some tips back home. Thank you.
Thanks so much. Sustainability is very important element. Maybe during my slide presentation to share with the experience in Ethiopia, non-communicable disease was not one of the public health concern in general at federal level. Recently, one decade history, formulating the national strategy and also making the agenda to lift up a higher level. So with that, with the recent health sector strategic plan, non-communicable disease and all this, the key major NCDs are boldly stated, and also the government provide due attention. Not at the health sector level, it's even beyond at primary health, prime minister level, so that considering lifestyle change, healthy lifestyle, nutrition context, healthy food, we are currently drafting unhealthy food proclamation. That's really one of the big agenda that will really making a kind of milestone that will to support the NCD prevention in general. The other thing, having the health system and using the integrated delivery approach, using the all health system delivery tiers, we consider non-communicable disease. Previously, mainly attached in the secondary and tertiary level. Now, PHCU is the main agenda and talking points everywhere. So with this regard, not only integrating the service, also taking the responsibility by allocating resource, by providing capacity building and so on, what the commitment and sustainability is now in place and further will intensify. Thank you.
Thank you. And the very final question, there was a hand there. Yes, please. This will be the last question.
Hello, Rasmus from Steno Diabetes Center, Copenhagen. I've worked in Ethiopia for more than 14 years with research, and I've been very impressed with the quality that's coming out of there. So it's a question for Hivot. You presented data from 2015. That's quite a long ago, coming to 10 years ago, with a 3.2% prevalence of diabetes, not distinguishing type 1 and type 2, of course, but do you really think it's 3.2? I mean, let's say that it's 5, then or 6, that's half of the Danish population that has diabetes. So what data do you base your planning on? Thank you.
Yeah, I really ask a kind of excuse because of the older data reflected on my slide. That was from the 2015 STEP survey. Currently, we conduct the same survey, but the data analysis is not finalized yet. Hopefully, in short time we can have that data. But just to consider, because that's a kind of national survey. In fact, with the health system, we started to generate the NCD data through our DHIS2 or Health Information System data. It's already there, but the quality has some issue. I don't want to share with that reservation. Thanks so much. But definitely we believe the prevalence is not the same. There will be much increment is expected with obvious reasons. Thank you.
Thank you very much. I'm sure we had more questions. We will have a second country panel after the break, and we will be able to discuss many of these other aspects from country perspectives and from the person with lived experience together. But we will give a round of applause to this panel.